All right, thanks for the introduction, Dr. Kim. Hey everyone, I'm Omar. I might have seen a few of you at clinic, but for those who haven't met me, I was doing my rotation and today's my last day on the rotation. And so my project I've been working on has been kind of a way to introduce national databases into the endocrinology department. So I was gonna give like a brief overrun to help everyone get situated of how to conduct this research. So I've divided up today's talk into four sections, with the first one being just being very general, like what are national databases and how can they assist in your research? And part two is going into designing a research question and how you can use a database to address that, as well as selecting the correct database and how to obtain access to the database. And part three is after obtaining access and signing all the agreements, how do you obtain that data onto your computer? What's the process of verifying that data? How do you go about loading it? What programs do you use? And then lastly, I was going to go over a few examples of some software tools that are used in the assistance of the data that you get from the database, particularly for ICD-10 codes. Okay, so first up, we have to ask the question of like, who's in charge of giving us this data? And the Healthcare Cost and Utilization Project, or HCUP, I'm going to be saying a lot of acronyms today, so bear with me. HCUP, developed through a federal-state industry partnership and sponsored by the Agency of Healthcare Research and Quality, or the AHRQ. And what they do is that they consist of like mostly databases and software tools and products that they design for clinicians, researchers, policymakers, and all types of people who are interested in understanding the healthcare data around the nation. And what they do mostly is that they're capturing the discharges of inpatient care and certain components of outpatient care from the community hospitals in participating states, which are to this date 49 states, including Washington, D.C. So the way the data is collected is the American Hospital Association categorizes hospitals under 5 main categories. You have community, federal, long-term care, psychiatric, and tuberculosis facilities. And HCUP only targets the non-federal community hospitals. So although that's only one of the 5, it makes up 85% of discharges and encounters across the nation. And that's a significant amount of data to work with. When it comes to like the types of care that's captured, they fall under 3 categories. First, we have inpatient, which captures discharge level data and specifies admissions and readmissions. And for database purposes, they define a discharge as a patient who has been admitted to the hospital for inpatient care and subsequently discharged. The next case we have is outpatient, which involves capturing encounter level data. And this encounter is divided into 2 subcategories of ambulatory surgery and emergency department information. And again, encounters are defined as a record that only includes information on outpatient services. And lastly, we have ancillary services, and this involves physician office visits, pharmacy, labs, and radiology. And it is important to note that HCUP does not capture any of this data. However, it is possible through billing codes to kind of retroactively work your way to understanding if certain patients obtain specific labs or radiology reports or certain pharmaceuticals as well. But it is not strictly directly linked to that patient record on HCUP.
Omar, I'm sorry to interrupt you. Can you go back?
Yeah,
quick
sure.
question. So basically, still we can capture some outpatient database is there, but however, that usually relate with the more like interventional service related
Correct.
outpatient care. Am I right? Got it.
Yes. So outpatient care is strictly capturing services that are performed, such as these are elective outpatient surgeries. Those are the type of things that would be still considered in the database. And they're, as I go into like describing more databases, you'll see examples as to what I'm describing of like what specifically would work and what would not be included in that database.
So in other words, if we are not doing any procedures, like for example, our weight management clinic, our patient will not be included in this database, right? Because this is just based on mainly the inpatient-based or procedure-based database. Am I right?
Very so. Yes, that's correct. All the other things you were mentioning were mostly fall under physician office visits, which would not be captured by HCUP. Okay. So going into databases, so there are quite a few databases that I'm going to give a brief overview of all of them. However, I am going to highlight three, which I'll explain all their abbreviations in a bit. But these three are going to be primarily the ones that I would use examples for going forward in this talk, because I feel like they would be the best to necessitate any research that would be done at the academic level for a teaching hospital that is working primarily with inpatient data. So to go from the beginning with state databases, we have the first one is the State Inpatient Database. It's abbreviated as SID, and it captures discharge level inpatient data in participating states. And its purpose is to study many state level issues surrounding healthcare, utilization access, charges and costs, quality, and outcomes. The next level is the State Ambulatory Surgery and Services Database, and this is capturing the outpatient encounter level data for ambulatory surgery and other services that include hospital-owned facilities as well as non-hospital-owned facilities, depending on the state legislature. And this is mostly used to study topics related to any outpatient procedures and follow-ups, including that. And lastly, we have the State Emergency Department Database. And this is strictly capturing just ED visits that do not result in admission to the hospital. And it's used mainly to study any healthcare topics surrounding ED visits and procedures that occur on that level. So when it comes to a database, in general, what you'd be getting is, for the most part, you're getting the hospital billing data that we also refer to as administrative data. And that's going to include the following information. You'll get demographic information, such as the patient's age, sex, and race, that is dependent on the state's policy. You'll also get some details of care, like the primary and secondary diagnosis, the primary secondary procedures, admission and discharge status, the length of stay, total hospital charges, and the expected payment source. And this data is contained into 3 files. First one is the core file, and this contains all the raw data. So this is what you'd mostly be manipulating in like a statistical program. And you would get all the data elements I listed above, as well as certain states will allow race and ethnicity. You can get patient county and zip code, the severity of the illness, primary payer details, secondary payer, and the physician's specialty if you want to, say, funnel a procedure that's done by multiple different disciplines, but you want to focus on a specific subset. The next file that you're going to get is the charge file, and this allows you to understand the total charges submitted by a hospital for each discharge, but this is not accounting to the amount reimbursed. So you have certain tools that you could use to convert the cost using the HCUP cost to charge ratio files to get a better understanding of how those charges translate across states. And then lastly, this is one of the state unique database features, which is an AHA linkage. So the American Hospital Association allows researchers to link hospital information from the SID database to the AHA annual survey of hospitals, allowing you to better track revisits and readmissions of patients. And a unique feature about the state database is that due to the regulations of coding, you are able to conduct state-by-state comparisons by purchasing 2 or more databases, because they have to be all following a strict code format to be able to be submitted into HCUP. So after I describe a database, I'm going to give a brief list of use cases as to ways to make you want to lean more towards using this database over others. So when it comes to the state inpatient database, these are the following use cases that I think would be applicable. If you had a scientific question that was only unique to one state that you wanted to research, then SID would be the best database for you to use. If also you wanted to compare 2 or more states directly, then SID would also be great, but you would have to buy a database per state, per year. If you want to understand how your state's specific trends in healthcare utilization, how the access changes, and how patient outcomes or charges are changing due to policies, SID would also be great. If you were interested in understanding race, diversity, and ethnicity issues affecting healthcare, then SID would be the only one applicable, given that it's the only that provides this type of demographic data. And lastly, if you wanted to be able to use another database like AHA Survey and study readmissions, then SID would be the only one that allows you to do that by giving you that linkage file that I mentioned at the last slide. Okay, so that's the state database. Now we're going to nationwide. And the first one we have is the NIS, NIS. It's derived from the SID, and I'll get into more details what I mean by that and how a national database is compiled. But in general, the NIS is used to identify, track, and analyze national trends in healthcare utilization, access, charge costs, quality, and outcomes. Then going next, we have the Nationwide Ambulatory Surgery Sample, or NAS. This one is the largest all-payer ambulatory surgery database in America. Again, you can see a trend here. This is samples from the state ambulatory service database, and it's used to create national estimates of all the ambulatory surgery encounters as in hospital-owned facilities, and it allows the use to contain clinical and research use info, including patient characteristics, clinical diagnostic and surgical procedures, disposition of patients, their total charges, expected source of payment, and facility characteristics. And then we have the NEDS for the Nationwide Emergency Department Sample. And so similar from the SEDD, the NEDS is derived from both the SED and the SID, and it's used to analyze emergency department utilization patterns to support decision-making regarding the source of care. And then lastly, we have the Nationwide Readmissions Database. And so this one differs a little bit because readmissions are not typically given on a nationwide database, but the NRD is derived from the SID, and it gives verified patient linkage numbers as well. And it allows research to estimate national rates of readmission for all patients to then understand the reasons for returning to the hospital care, and then to understand costs and discharges both with and without readmissions.
Omar, just quick question, sorry. Before I forget, so this NIS, NASS, NEDS, all this is separate database? Or
yes, each one's a separate database.
I got it.
Yep. Okay. So how are national databases compiled? So I'm going to use the NIS and the SID, for example. So those are the counterparts, nationwide and statewide. So the NIS is derived from the SID, and what it does is it takes an approximation 20% sample of all discharges from HCUP community hospitals across the United States. So all 49 participant states, it does this a striated 20% sampling of each. And with that, it allows us to allows identification to track, analyze national and regional healthcare trends. We also can get charge information that's regardless of the payer, and that can be converted to cost. So it is important to know that the national databases, they don't just focus on Medicare or Medicaid. They use all payers. So you can get a lot of cost data done. However, it's important to know that since 2012, we used to provide hospital identifiers that permit linkages to other databases. And now in national-wide studies, that cannot be done. That's still done on the SID if you were to purchase like multiple states. But as of now, nationwide, it's not being done. But however, you do get around 7 million hospital discharges. It's a lot of data to work with. And it is important to note that when you have the NIS, even though you have all the states, you cannot do a state-by-state analysis. You could do region by region because it can be divided as such, but you cannot identify just Massachusetts, for example, and compare it against California with this database. So in general, the NIS allows for national estimates, but you do lose out on a bit of data, such as certain demographic info, given to the differences across states and what they allow or disallow for sharing that data.
Sorry, 7 million is per 1 year or entire?
7 million per year, yes.
Wow.
Yep. It's a lot of data.
So Omar, so NIS data, we don't have like demographic information, or do we get the diagnosis, like primary reason for admission, or is it just mostly quality based, like the costs and the trends?
Yes, so you would get the primary diagnosis and secondary diagnosis, and you'll still get demographic info in terms of age, sex, and they give race and ethnicity. And I think race is the one that supersedes in being more generalized. I think ethnicity is more specific, and that's the one that's state by state, I believe. Yeah. Okay, so going forward, now going into the NIST use cases. So I would suggest that if you want to use the NIST, you want to understand how hospital services across the nation are being utilized, what's becoming, what's trending up, what's trending down, what procedures are being more utilized, what's being diagnosed more often. NIST is perfect for that. If you want to understand regional trends, so you want to compare like the Northeast to the Northwest, based off like different changes in like climate or different changes in policy. Like good example is like how we're handling mask mandates. Like you can understand that data because you can break down region by region. Third point was if you want to understand like national charges and costs that's going on and you want to compare how different regions are handling it, then this would be great as well. And then the next 2 points for medical practice variation and medical treatment effectiveness, based off the diagnostic codes and also based off procedures, and you can also get comorbidity assays that will go into more detail. You can kind of essentially trend how doctors are making different decisions across the nation and then use that as well to study. And then the last ones are, quality of care and patient safety. Again, we can't use readmission necessarily for patient safety in a NIST, but we can understand like how there's different diagnostics are going. What is the primary diagnosis? How does that change over time? And then lastly, the impact of health policy changes. So if on a federal level, something's being done, we can see how that changes if different procedures are changing or different diagnosis or treatments are being done. Okay, so now onto the National Readmission Database. And this one is, again, derived from the CID, just like the NIST, but it's only emphasizing hospital readmissions for all patients, regardless of the payer. And what you get is that you get a synthetic code that allows you to track hospital visits for someone who's revisiting that hospital, so that the medical record is not given away, nor is it any patient secure data, but you still are able to track that as different data entries in the NRD. With this database, you're actually gonna get 14 million hospital discharge records. And certain outcomes of interest would include your national readmission rates, the reason for returning to the hospital for care, hospital costs for discharges with and without readmission. And it's important to know that there's 2 variables that would be unique to the NRD. The first one is visit link. This is the linkage variable I mentioned before. So it is a synthetic number and it's going to adhere to the privacy guidelines, allowing you to track readmissions and even at different hospitals as well, if that same patient were to go. And another one would be days to event. And this allows you to calculate the number of days it's been for a patient between admissions so that you can do a lot more medical outcomes and patient outcome research as well. And so to briefly go over the NRD and use cases, anything that's involving readmission, NRD is the way to go. You can also understand readmissions if across different demographics or minorities. You can use that as well, because then you can see how certain ways of treatment is being done and how that affects how often they're able to go. If you're interested in studying disabilities and mobility access, NRD would also work because that is affecting their rate of readmitting to the hospital. Payment sources, you can see how maybe certain insurers are more likely to allow someone to readmit, whereas other people might be hesitant because their insurance might be more conflicting with them and staying at the hospital, as well as negotiating certain costs. And lastly, the impact again of health policy changes, depending, like for example, as we saw last year, we had with COVID such a change of the hospital dynamic that readmissions were definitely going to change. So I'm actually interested to see how 2020 would have changed the NRD in terms of how many people actually went to be readmitted in the hospital during that time, unless they absolutely have to.
Oh yeah.
So oh yeah, go ahead.
Yeah, go ahead.
Did you have a question?
So I just actually I want to know between major difference between NIS and NRD. So, but you already showed the slide. Please go ahead.
Yeah, I thought ahead. Yep. So I know I said a lot, but here's a breakdown between or among all 3 of the databases I emphasized. So again, going from left to right, we have the state inpatient database, the nationwide inpatient sample, and the national readmission database. And so again, to specify, I won't go over each bullet point right now here, but state, if you're focusing on just one state or directly comparing a state to another, or even a few more, but doing direct comparisons with statistics, then you want to focus on the SID. If you want a lot more demographic information, you also want to focus on the SID. If you're focusing on national trends, you want to see how the entire country is doing in terms of like hospital services, hospitalizations, procedure changes, diagnostic codes. You want to stick with NIS. And then lastly, if you are very interested in understanding readmissions, how patients come and go through the hospital, and you want to track that data, then you want to go with the NRD.
Basically, variable wise, can you go back the slide?
Sure.
NRD and NIS has more data variables, right? NIS is like a little bit more limited data, like a data variables. The variable wise, right?
I would say, I mean, it depends. Like, you know, the SID has a lot more demographic variables that you can utilize. The NIS just has, I would argue, like the best normalized data, the best basic normalized data, because you get a very good sampling across the entire nation. And then the NRD is like a use case specific. And like, I also forgot to mention a fourth database, which is called the KID. This one is specifically for pediatric patients, so anyone under 18. So it's just like the NIS, but under 18. So it really depends on your use case. Like if you really know, like if you know what question you want to answer for a data analysis, then picking the right database, you're pretty much going to only be stuck with one or two. Like it's not too hard to choose the wrong database, and data variables are roughly the same, but there's like a few perks here and there. Like, you know, NRD has that linkage number, SID has the demographic, and NIS has the most broad inpatient data. Yep. Okay, so to go over benefits and limitations, for benefits, you know, we get a very large amount of records, and this is this data is collected routinely and annually. So every year a new one gets published. It is a few years behind. The latest is 2018, but this does take some time to you know, synthesize and to organize before it can be sold to people who are interested. But you do get a rolling yearly, like 7 million data for the NIS, for example. You also get all payers, and the coding is done uniformly across states, which is easier to compare. You do have ease of access. HCUP, the website, offers, you know, a lot of support, a lot of tools. It's very straightforward. I'll go over and give hyperlinks to show you how simple it is just to like learn about it. You can study your data at a local, state, regional, and national level, but that's dependent on which database you choose. And of course, there's a bunch of tools that can help you assist with your research that HCUP offers. Now, on to limitations. You do have some limited clinical details. You are not going to get the whole picture. So you're not going to have office visits. You're not going to have ancillary testing, no labs. So that does kind of cloud what's really going on. Hospitals do code a little differently, though they have to follow a uniform standard. They may not necessarily code things correctly. So you could have some missing data at times. Again, you're only using the non-federal hospitals, but that does make up 85% of the hospitals in the nation. You do not understand the full, complete episode of care. So that's similar to like the limited clinical details. Because you're not seeing office visits, because you're not seeing many outpatient services, you may see a lot of patients who have diabetes, who may have had bariatric surgery, but you may not have been able to understand like how well their weight loss progress has been going, for example. So you are missing blanks of their actual medical care. Also, no data is involved in individuals outside the hospital system. And lastly, you cannot link national databases to any external sources anymore, because that was banned since 2012. Okay, so part one is the biggest part. So don't worry, like we have, you know, we went in like 27 minutes, but the rest should be a little bit more straightforward. So part two is about designing a research question with your database in mind. And so I broke it down to 6 questions. And if you can answer all these questions, you can narrow it down to one database. So first is, what is my research question? So do you want to study a certain comorbidity with a primary diagnosis and see how that goes over time and how that's changing? That can be a good start for a basic question to go from there. And then you would go further, like, do you want inpatient or outpatient data? So one of two. what variables do I need for my analysis? And that depends on like, do you want diagnostic codes? Do you want procedure codes? Are you interested in the demographic data? So things like that can really narrow down which database you want to select. Next one is, do I want national estimates? Because that determines if you want a state database or a national database. And then, are you interested in readmission analysis? If you say yes to that, you literally have one choice, which is the NRD. And then lastly is a pediatric or adult. So again, I mentioned earlier that there is one more database called the KID, and that is the NIS under 18. And so if you answered pediatric here, that would be what you would select. Okay, so before we understand the data that we're going to get, we need to understand a few parameters of sample design. And so these are some 4 basic definitions of things to help us understand what our database is actually sampling. The target universe, that includes all people or entities that we wish to understand. So if we want to focus on a hospital or emergency department. The sample frame is going to be a subset of that target universe that we will study to make inferences about that. So that is if we're going to study on a state level, inpatient, emergency department, ambulatory. So the way the state and national databases subdivide is the sample frame. The sample strata is a way to relatively make homogeneous groups from that sample frame. Because if we can make more normalized data, that allows us to compare better trends as opposed to having data from like the very youngest of a nation and only the very oldest and no one in between. So by having normalization by sample strata, this allows us to have data that will fit tighter for our analysis. And then lastly is the level of sampling within each strata. Are we focusing on a hospital level, a discharge level? Is it going to be inpatient or outpatient? So I'm going to tie these to some examples. So for our target universe, typically HCUP is our target universe. So that's all US community hospital discharges from the AHA annual survey of hospitals. So that's what HCUP derives its entire database from. The sample frame, if we use inpatient databases, the vast majority of HCUP is inpatient. So that's over 95% of the target universe. And then for sample strata, the next slide, I'll go into this more detail, but basically you can divide it by region, which is the same regions that the US Census describes. You can do it by urban or rural location, the teaching status of the hospital, the ownership, the bed size. But this, to keep a note, this cannot be used for state level analysis. This is how the national databases get its 20% stratification sample. And then the sample unit, again, randomized 20% stratified sample of the discharges. They can be stratified by hospital characteristics, such as its size and teaching status. It can be sorted by discharge characteristics like the disease-related group and the admission month. So from where we take our target universe, sample frame, and strata, how we further define it with our own research is the additional parameters we add onto that sample. So here's a picture of the census divisions of the United States. So there's 9 regions. And again, you know, we divide by urban and rural because urban hospitals have very different sizes, very different priorities than a rural hospital. So it would be very difficult to compare those two across the nation if you want to get a national trend. Then we have teaching status. Is it an academic or non-academic? We have to consider financial considerations. Also, academic hospitals have both residents, fellows, medical students. Those all have liability. So there's a lot of money that goes into that. So that changes the way priorities are done for medical treatment. Also, there's ownership. Like, is it a public hospital? Is it a private not-for-profit or private for-profit? Because again, they would have different mission statements, resources, and responses to certain events and tragedies. And then also the bed size. Like, you know, is it a hospital under 50 beds? Does it have around 100? Is it over 200? And then this actually has cutoffs that differ between rural, urban, non-teaching, and urban teaching hospitals, given that each scenario would have to have a different hospital, or there's probably way more hospital density in certain areas versus others, which have to be a broad approach due to like not having a hospital for many miles away. Okay, so after you understand what you want to do for your research, the next step is the requirements to actually obtain this database. So anyone who wants to purchase this database can do so but needs to first complete a training course. And this training course is offered, at that hyperlink that I have here. I'll have Dr. Kim like distribute this slide deck so everyone can have it, because everything that's in blue is a hyperlink I designed to help you just jump right to where you need to go. So you don't have to like scurry through the entire website. And you've completed a training course, which is just watching a few videos, and you have to take a quiz at the end of each one. And then you sign a data use agreement. And you have to complete the following agreements here as well as complete a guide of preparing a statement of intended use. And this is very similar to an abstract, basically. And if you are ready to buy the data, you can just click right here, and you would go to a link where you can purchase it. And I'll show you in a bit how much the price would cost. So like I said, the statement of intended use is around a 250-word narrative where you essentially address those 6 questions I had at the beginning of part 2, which is, what's your question? Where are you going to be looking at it? Who's the intended audience? What's your final product? Are you going to be focusing on certain regions? How are you going to actually produce the data? Is it going to be a report, a table, some graphs? Who are you targeting to read the data? And then, of course, like your privacy statements, and like to ensure that you will keep this data secure, because they really, really care that this data does not go to the wrong hands. Okay, so after you've done all that, you can actually go and buy a database. And you can see right here that databases are pretty pricey. But as you start from older dates, they are relatively cheaper. It's of note that 2015 was when ICD-9 was about to stop and ICD-10 began. So 2015 has a mix of both. And then also 2012 was the date where there was no more linkage files for national databases as well. I think the best rule of thumb is if you want to buy a database, get a med student to do that. It's way cheaper. As you can see right there, 150 over 750 for 2018. So keep that in mind. Okay, now going on to protection of individual identities. So although the database is stripping away all the specifying data of a patient, it is still possible to actually retroactively or reverse engineer who that patient roughly is if there's certain key delimiters, such as very rare diseases, that would allow you to identify who that patient would be. So data use actually prohibits the following. If you're doing any study that's focusing on a very rare disease, and at the end of it, you have on a region by region or state by state level, an N number less than 10, you cannot report those findings because that value is too low. It could suggest that there's probably 1 patient per hospital who goes for that condition, and it would just, it would jeopardize their identity. Again, I can't say this enough. Do not attempt to learn the identity of any individual. Don't publish methodology that can be used by others to identify individuals. And although you get the hospital identifier number in every database, when you are publishing the data, you must not disclose any of that specific data. You must always aggregate your hospitals. You will be able to list which ones you were identifying, but when you are showing data, it is best to aggregate them all together because you do not want to disclose which patients are coming from which locations. Okay, on to part 3. So you've obtained the data, and now you want to understand how to actually use that data. So first off is, if you are doing it alone, then like you're good to go right now, if it was just you doing research. But if you have anyone else involved, you need to ensure that they get the same training that you did. They sign the same data use agreement. You as the purchaser must take all of their signed agreements and then send that to the central distributor so that they know who's responsible for all data management. And that it is very important that you keep this data in a secure environment and that only the authorized users will have access to the data. So don't put it in the public Y-Drive. Just put it anywhere that has encrypted access. So when you get the data files, you'll have roughly 15 gigabytes, give or take. You'll be given the password, and then you'll be able to unzip that file onto your desktop. The format is done in a way, it's in the fixed width ASCII data file. ASCII is a very light format for data entry. Excel uses XLS, and that has a lot of bulk to it per data cell entry. So when you're managing millions and millions of rows, we use ASCII as a simpler way of managing that. But it comes with the side effect of you have to use certain programs instead to manage that data. But anyway, when you get that data, you get the following files. You get an inpatient core file, which is at the discharge level. And this is sampling all hospitals in participating states. You get a hospital weights file, which is able to link inpatient. It can show you at the hospital level for each record in the hospital, you will get a linkable file to that inpatient core file. Keep in mind that the inpatient core file, that is the raw data. So this is the data that you'll be manipulating the most, and the others will be used as reference data. So going forward, the disease severity measure, this is something that uses a way of understanding comorbidities and how severe someone's diagnosis is by using a certain algorithm. And that is again on the discharge level. And lastly is more of the billing or the coding for ICD-10, which is the diagnosis and procedure groups file as well. Okay, so to give you some variables so you can understand what you would get from a data sample. So in the core file, you would be getting the following. You get like things like age, the month of admission, if that admission was done on the weekend, if the patient died during admission, the diagnosis related group, if what was done at the visit was elective, the sex of the patient, the ICD-10 CM code or ICD-10 PR code, the NIS record number, which is the unique identifier per patient, the length of stay, the primary payer, the race, and again, like race would be given on a national level, but ethnicity would be on a state level. And lastly, the total charges. As for the hospital weights file, you get the hospital identifier number. So this is the number I mentioned that you do not want to publish. If you were to make a publication, you would have to aggregate this because if you do not want to link hospitals to patients. So this number is something that you would do privately. Number of hospitals in the stratum, a discharge weight, which is something that you can use if you want to trend over years. So if you want to study from 2017 to 2021, how things are going, you need a discharge weight file, which is provided for every database you purchase. Also the bed size, the census division, and the teaching status of each hospital. And then for severity, you get risk mortality, the severity, and a patient-refined disease-related group. And I have here, if you want to see all data files, this will link to an HTML, which has the entire list of every variable so that you can approve, you can review everything so you can determine if that's really what you want out of your database.
So sorry about that. That will be we can see some samples with the link, samples of all the variables with the.
Yeah, right. So right here, yeah, this will give you like it will link you to a page on the website that has every data variable that's provided in the data file.
Great.
Okay, so now we're going to do a little bit of a data run or a little demo of just like some steps that you can do. So this was designed just if you were getting the database right now and you really wanted to remember how to do everything step by step. I just had a bunch of these screenshots taken to show you just some basics of how to get the program started. So you get the data, you unzip it, and you put it in your desktop. And I recommend that if you want to make this easier to follow along, it's best to save your data in your C drive, label it, if it's a NIST database, NIS, this example uses 2013, so put whatever year you have here, but just try to keep it in a simple pathway because you're gonna have to do a little bit of coding at the beginning. And before we start, again, given the format of how this data is compiled in the ASCII format, Microsoft Excel is not gonna be recommended to use here. It is better to use programs like SAS, SPSS, and Strata. And so I have links here that show not only guides to each one, but also a load program, which you would just have to click and copy and paste this text, and it will already compile the data for you. So it's easier for you to review once you get access to it. So this is an example of what I'm talking about. So I'm going to use SAS as a loading program on this demo run. And you would click on this hyperlink. It would take you here to this page. And you would just select which year your database is, as well as what type of database you have. And then you want to select that you're doing the core file, because that's all the raw data. When you click that, you're going to get a text or a notepad that has all of this text. And it will literally say here, this program will load into SAS. You want to take that, copy, and load up your statistical program. So for this example, we have SAS. It's here on the bottom right. You want to then paste this entire information into into the text line here, and then you will save that into the same folder as where your database is located. And then the next thing you have to understand is that you need to link the SAS program to the actual database that you've purchased. So the best way to do that is with this command that you can put up here at the top. You put the command libname, and then you specify that this is the national inpatient sample, and then this, and you put the pathway. So again, I told you to use this as a simple pathway because all you do is just copy and paste that, and it'll put it in right there. Okay. There are a few adjustments that you have to do, and I just wanted to make this very simple for everyone. So I just highlighted in red, or I put in a red box here, the parts that have to be changed before you can run the program. And I put here exactly what you're going to change it. So here I said change the NIS_2013 core, change that to NIS.NIS_2013_core with a semicolon. And here as well is to put the location of the core file as well. And you just got to make that change. It's, for some reason, it repeats twice for that pathway because it's a subfolder within that you make now. But just these two text changes, you can copy and paste that and put that in there, and it should work just fine. Okay, so after you've done those steps, it's time to test your data. So you're going to click run, you're going to hit submit, and what's going to happen is that it's going to run. It takes a few minutes, and when you're done, it will either give you one of two things. Either you're going to have an error, which would be at the very bottom when you scroll down, and it'll tell you what's wrong, and that means you have to just look back and maybe you wrote something incorrect in the coding. Or if it's correct, then it would show you how much time it took to run the software. And when you're done, you're gonna get something like this. So you're gonna get a table. Now this is of course censored for patient safety, but each row is going to be a unique identifier. So each row will be a patient roughly. And each column you can see here, I know it's a little blurry, but we have like, how the age of the patient, the admission month, if that was it on a weekend, did the patient die during the service? What is there a trend weight to compare year by year, and the disease-related group. So you get all this data, and the question is now, is this data actually correct? So you need to verify it before you want to do any further analysis. And I recommend using, there's a lot of tools that HCUP has, but the one I recommend is probably the simplest is you want to go to NIS Summary Statistics. They publish this every year. And you could see here, again, I know it's a little small, but you can see that it has a N value of every single criteria. It also tells you how many of those samples were missing, what was the minimum, maximum value, mean and standard deviation. So you get a lot of basic statistics that you can use. And what we can do with that is by comparing this table, we can run a small little statistical program. So if using very minimal like coding, we just run this following line, which is we want to proc, or we want to compute the means of the data from the core, and we want to run it. And what you'll get is something similar. You see like there, the first line is age. It's 700 or 7 million, 7.1 million. If we go back, about 7.1 million. So that's like a way to confirm that you have the actual correct data. There was no further manipulation done, no fraud, none of that. So very important to do before you go forward and doing like, further deeper analysis. Okay, now we're wrapping up. We're on part 4, and I'm going to explain a few of the software tools that HCUP offers to assist for clinicians to do further deeper research with ICD-10 codes. So just to give a brief description, the ICD stands for International Classification of Disease. It's done by the WHO, and it's applied for all member countries involved. And these codes contain conditions, treatments, procedures, symptoms, external causes of injury, social circumstances. It's leveraged for clinical, epidemiological, and quality purposes, and it includes reports of mortality and morbidity trends. And the ICD-10-CM code is the diagnosis coding system for inpatient and outpatient medical encounters, whereas the procedure code is for inpatient procedures. And what's important to note when you work with the database is that the ICD-10 codes are released annually in July, and they typically run from October 1st to September 30th. So it's very important that when you obtain a database, you are using the correct ICD-10 codes at the year that they were released. Okay, so this is one of the software tools that you could use. This is called the Clinical Classification Software Refined, or CCSR. And what it does is that it takes the over 70,000 ICD-10 codes and it converts them into 530 clinically meaningful categories. These categories are across the 21 body systems, which is similar to how the ICD-10 teaching process is for diagnosis in the chapters. So you can see on the right, this is a breakdown of the 21 systems. And so you're able to then, with that data, understand through diagnosis codes what other flags are coming up in parallel. So as an example here, diagnosis code I13.0, it stands for hypertensive heart and CKD, with heart failure and stage 1 to 4 CKD or unspecified CKD. So from that single ICD-10 code, you can map it onto 3 CCSR categories, given that the diagnosis code includes 3 different diagnoses. So we have hypertension, heart failure, and CKD. Now, because heart failure is now considered the most severe underlying cause, it becomes what we call the default CCSR code. So it overrides and becomes the hierarchical for this, which is very important, as we'll see in a bit, about how you can categorize your data using that system. And so again, I have the files here. I won't go into too much detail right now, but if you want to get the CCRS code for ICD-10, all you do is just click right here. It is only available in SAS, statistical program. So there are some guides to convert to STAT and SPSS, but we recommend just use SAS if this is like your first time and you're new to using this database.
So that
you get 2 files.
Sorry. That is separate program, right?
SAS is a separate program.
No. This click, the download click is totally CCSR is totally separate program, right?
Yeah, it's like a tool. So you can you can get it for free. But it works. It's specifically designed for the database. Yeah. And just going over briefly, it comes with 2 files. One is for mapping the codes to categorize them as such, as I described earlier. The other one is as well using it uses SAS to actually map the program itself within it. So these 2 are used in conjunction to allow you to use the tool with your database. So here's kind of an idea of what I mean by what you can get out of using this software tool. On the top image, we have one patient ID. That's the rec ID over here. And this simple patient record had 8 diagnoses, which are listed across the board here. And those 8 ICD-10 codes triggered 11 CCSR categories in the output file. So if I now show you like the bottom picture here, you can see that the same patient ID, like 1001, so it's all the same patient, but there's 11 unique categories that were triggered. And so again, first one's the record identifier, second one's the number of codes. The third one is the name of each CCSR category, so what would that correlate to. The next one indicates which of the ICD-10 codes on the record triggered the category. So you can see, for example, there's 2 that are paired with 8, 2 with 7, and 2 with 1. So that means that one code triggered 2 different CCR categories. And then lastly, on the 5th column, if that is the default CCSR, just like with the heart failure in that previous example, it would have a symbol of Y. And if it's not, it would have a symbol of N. And so this is kind of an idea of what you could get using both the database and the CCSR. You can essentially be able to understand from principal diagnoses the number of stays and the rate that's going on inpatient in the United States at a particular year. This would not be able to be done with just the national database because it's using only uses the billing codes. But by using CCSR, you can then specify exactly what categorization you are going for.
So sorry about that. So in other words, this NIS raw database does not include this, CCSR like detailed diagnosis, right? So if we want to use more detailed diagnosis, we have to use this additional program to expand our database. Am I right?
Unless you want to use the ICD-10 codes as your diagnosis, which can be used, but it would probably be advised to use clinical the clinical database instead. Okay, and then my last example here is another one, and this is for comorbidities. And what this does is that it focuses on the secondary diagnoses. So there are ICD-10 codes that are really hard to differentiate, but this software categorizes and subcategorizes a primary diagnosis from a secondary diagnosis to allow you to extrapolate additional things that would be having a high correlation with your primary diagnosis. And it can be done for inpatient and outpatient as well. So what it does is that it takes the ICD-10 diagnosis code with indicators of whether the diagnoses were present on admission. And there are a total of 38 comorbidity measures, with 18 out of 38 requiring something to be present on admission, which means it has to have been notified and documented when a patient entered. And again, I have given the file. You can, if you want to use that file, you just click on this hyperlink. It also only works on SAS, and you also get two files. One allows for the formatting, and then the other one allows for SAS to actually utilize the program to then categorize the data as such using comorbidities. Okay, so I know I said a lot. We're about approaching the hour, and so in conclusion, I wanted to sum it down, summarize it to 4 points to summarize each learning objective. So first, HCUP allows for your national and statewide discharge level data to give you the power to determine trends within a subset of the population. You can go on local, regional, state by state, or nationwide, depending on what database you choose. Point 2 is that prior to obtaining data, it's very important you design an appropriate study. The best thing to do would be to get the training and then to actually work on that 250-word abstract so that you know exactly what question you're doing before you purchase a database. That would give you a lot more ability to select what is the best database for you to utilize, and also to adhere to all privacy statements. Number 3, it's important to note that the data is provided in ASCII format. There are specific tools that are better suited for handling that. I mentioned the 3, SAS, SPSS, and Stata. But those would be more preferred over like traditional software such as Microsoft Excel, given that Excel would probably have a lot of difficulty running 7 million entries at once. And then lastly, HCUP site offers a lot of software tools. I only mentioned a few just to give you like an appetizer or so about it. But you're able to use ICD-10 codes, even CPT codes. There's also both comorbidity, mortality analysis. Some are in beta. There's a lot of new things that are coming out as well. So, I recommend the best thing is definitely go explore the website, take a look at this slide deck, click on some of these links, and just go out and see if this would be a great way for you to do some research down the line. And that's it. That's my talk.
Wow, great job.
Thank you.
Very excellent. Just a couple more questions. So first of all, so when we submit the abstract, no matter what we're writing about the abstract, still we're gonna get the raw data, right?
It has to be approved for the abstract needs to be like you send it, it's under approval, and then you have to also get the training, sign all the agreements, and then when they send you approval, you can buy the database. So
I mean, my question is like for example, I'm writing about some bariatric care or bariatric care, this kind of database, and then I make some hypothesis, and I wrote abstract and then submit it, and then but still they're gonna give us all kind of like 100% raw data, not just limited variables, right?
So you would get, for example, like if you want the national, the NIS, you would be getting that entire, whatever year you purchased, you'll get that year, and you're getting 20% of all the patients across the nation, because it has to normalize it with those different parameters like the census, teaching versus non-teaching. So as you specify which part of the database you want, it would give you that like section.
I mean, sorry about that. My question is about the variables. So if I just want to, I don't actually, at this time, I don't care about the, like someone who has a kidney problem, but if I submit just for the heart disease, like, abstract, but still I can get some kidney disease related database
Yes.
too, right?
Absolutely, yes.
Anyway, it's very excellent, really impressive presentation.
Thank you.
Anyone has any, do you have any comment?
Omar, excellent presentation. I mean, I learned a lot of things that I didn't know before. One question, so for the outpatient database, is there a separate database for how do we access a specific hospital or a specific state outpatient visits?
So the only thing that's offered outpatient would be ambulatory procedures. So anything with an office visit is not collected by HCUP, so that's not accessible.
Okay, so that will be like if we want to do some study, like a short study for our hospital, that we'll have to just do individual like chart review and look into our visits, right?
Right. That's why I highlighted the SID, the NIST, and the NRD. I think those are the most appropriate for the endo department to conduct research if they want to buy a database.
Mm-hmm. Okay. Thank you.
You're welcome.
So, I mean,
Omar, but the main, oh, sorry.
Yeah, go ahead. Yeah, go ahead.
Omar, but the main, thank you so much for all your time. It's great. Thank you for the information. But like you're getting ICD codes, you're getting readmissions, like you're not going to get necessarily, I guess you said something about weight at some point, but I guess in that, I'll just have to look at the variables. You don't get like hemoglobin A1Cs, or you don't get, I have to look.
Yeah, you will not get lab values, unfortunately.
You wouldn't get anything of that sort. You would get, and then I guess you'd have to depend on if you're using the later one where you're saying about the clinical diagnosis or not the ICD, like differences between type 1 or type 2, or you wouldn't like those, but you would get those, I guess, because those would be like ICDs, or they could be, okay.
So long, if there's a way in the IC10 code, because I'm not too familiar with the codes as much as all the attendings, but if there's ways to differentiate to know kind of like where someone's A1C roughly would be, then that would be the best bet of like using A1C data without having the actual data.
Okay. Yeah, no, not that I know of. I'd have to run it through other people if I could tell between like if the A1Cs, but like for example, like thinking about, admissions with COVID and then post-COVID diabetes, which we're seeing a lot of, like diabetes that is admitted, that a diabetes diagnosis post-COVID, whether you could do it like type 1s, type 2s, but you probably could, because those are ICD codes and those are, yeah.
I would say you can definitely have categories of like post-COVID, and then you can also then with all the post-COVIDs who had diabetes, and you can filter between just having specifically type 2 diabetes. If that's the trend that you've been noticing, that you want to see if it's happening on a nationwide scale.
BMI part of the BMI would not, because that would be like kind of a lab, or
I did not see height or weight data.
Okay.
Yeah,
I'd have to check on that.
So this what I know is this database is based on billing, is kind of key point. So like maybe this kind of like some specific patient information such as weight may not include it. I'm not sure about that. And
I'm not entirely sure.
And also like that's Ivania, that's kind of interesting question about COVID, and but that will be, we can get the data after 2 years later, because usually Omar, you mentioned that it will take some time to publish those kind of database, right? So if you want to get like a 2020 data, maybe we have to wait for 1 or 2 years later, and then we can see the data.
So like you wouldn't be able to use to me,
So most recently,
the last 2 days, I've seen a couple of
2018. Patients. So maybe 2 years later, that will be really interesting topics, like even COVID.
By then there'll be tons published. There already is a fair amount published already on this phenomenon.
And also, I just want, actually, GSOC is one of my previous, student, and he also mentioned about this. As you know, we cannot use this database to publish to NJM. And there's a limitation. As you know, this is limited database, but still, like kind of some decent journals, such as like gastroenterologists or endocrinologists, still we can publish a kind of really decent journal with this database, and it is already published. You know, a lot of people use this database to publish those kind of decent journal. So, you know, my opinion is, I think, you know, at a certain point we have to use this, you know, tool, and you know, we can share.
But the only one, Omar, the only one with ethnicity is the NIS, right? Or right?
That would be the statewide, would have ethnicity. But if you want just general race, which is the same thing that they use for like job applications, for example, I think that's available nationwide.
Oh, like let's say you're looking at like post-gastric bypass readmissions or something like that, and you wanted to include race. Is that only you? I have to look back at you did very detailed job. Yeah.
I want to see
in that case, what I understand, we have to use SI, you know, state database if you want to specifically like indicate for the, you know, bariatric surgery and
we need to know like what do they disclose in demographics.
Yeah. But like you said, Omar, I think it's all about doing your abstract and then going from there to see what the data is. Yeah.
I have an answer to your question though. So I just did a little quick search, and so this is only available. The following is available. So you can get like race and in terms of white, Black, Hispanic, Asian, Pacific Islander, Native American, or other. So it doesn't go much more than that. Ethnicity gives you a bigger breakdown. So I think this would still be sufficient if you wanted to do with like racial disparities, minorities, and different racial groups and how treatment changes. I think it still is a good amount. But if you wanted to go in more detail, then a state database would be more appropriate.
So even that means even national database, still we can, NIS still they can have some at least like African American and you know, Hispanic or some Asian just major. Still we can see those kind of variables.
Yeah, and I forgot who asked about the BMI. That's not available, unfortunately.
Yep. Okay. Great. Anyone has any?
Thank you so much, Omar.
Yeah. Any other questions?
You're welcome.
Okay, great. Thank you so much, Omar. This is really great. You know, it's
no
really
problem.
Yeah.
Dr. Kim, I'm gonna send you the latest edition so you